Hello, everybody, and welcome back to the channel. Today, we are diving into pancreas, a powerhouse organ that's often overlooked until it becomes the focus of your sickest patients. Pancreas is a retroperitoneal organ with both endocrine and exocrine function. It has got three segments: head, body, and tail. The head lies in the loop of the duodenum, the body is posterior to the stomach, and the tail goes towards the hilum of the spleen. In ED, we mostly see it when pancreas is inflamed, infected, or hemorrhaging. Now, there are two main types of inflammation that we need to talk about, and that is acute or chronic inflammation. Acute inflammation or acute pancreatitis is a very common ED emergency, and we have to remember the causes of acute pancreatitis, which can be done through this really easy mnemonic: I get smashed. I stands for idiopathic causes, G stands for gallstones, E for ethanol, T for trauma, S for steroids, M for mumps, A for autoimmune, another S for scorpion stings, although it's very rare, H for hypertriglyceride, E again for ERCP, and D for certain drugs. Bear in mind that smoking and diabetes are also independent risk factors for acute pancreatitis. The clinical features or the classic symptoms are severe epigastric pain that radiates to the back, nausea, vomiting, and tenderness. It can be alleviated by sitting up or bending forward. And if the patient also presents with jaundice, consider the possibility of an obstructive process, so something like a gallstone or tumor. As for the diagnosis can be augmented by checking lipase or amylase level. The idea is that these tests should be at least 3x their normal for it to be considered positive. Remember that lipase is more specific, peaks quicker, and remains elevated for a longer period of time than amylase. We can do other blood tests, so CBC, UNE, CRP to look for any systemic inflammation, LFTs to look for any gallstone or obstructive causes of pancreatitis. It is important to note that ALT is around 95% specific for biliary pancreatitis. Otherwise, we can also send for calcium levels, triglyceride levels. Do not jump to CT early. CT is generally recommended in three scenarios only. One, if the labs and enzymes are normal despite high clinical suspicion. Two, to rule out any other pathology that can present similarly and the index of suspicion is high. And three is to assess the complications. Generally, if the patient with pancreatitis is not improving by 48 to 72 hours. So, if we have to do CT, the CT of choice is CT plus IV contrast. Now, pancreatitis can range from mild self limiting to life threatening, and a severity score generally helps us to identify the disease course. We have a lot of scores: Ranson criteria, Apache 2, BISAP, but the one that we're going to talk about in detail is Ranson because it is one of the most popularly tested and used scores. The thing about Ranson criteria is it has to be done twice, one at the time of admission and one 48 hours after getting admitted. So there's a good mnemonic to remember: the admitting criteria and then the 48-hour criteria. It's called get a lawyer, can hob be saved. So, get a lawyer basically is GALAW. G stands for glucose, usually more than 200 milligram per deciliter. A stands for AST, more than 250. L stands for LDH, more than 350. Age, that's usually more than 55 years. And WBC, more than 16. At 48 hours, it stands for calcium less than 8 milligram per deciliter, hematocrit drop more than 10 units, PaO2 less than 60, base deficit more than 4, blood urea nitrogen more than 5, and sequestration of fluids more than 6 liters. So, this is an easy way to remember Ranson criteria. The management priority or principles for acute pancreatitis is basically to give fluids, to give analgesia, and to consider giving them antiemetics if they're actively vomiting. These patients are generally extremely volume depleted because of multiple factors: decreased oral intake, vomiting, third spacing. So, the idea is that we need to give them 250 to 500 mils per hour boluses. Generally, ringer lactate is preferred than normal saline because normal saline can create this acidotic state, and we know that acidosis worsens systemic inflammation. Previously, it was also thought that NPO is a gold standard of management because they thought that if you don't give orally or enterally, then you are basically preventing the disease from getting worse, because if you eat, then you stimulate pancreatic secretions. But we now know that this practice is actually counterintuitive and detrimental. The other end of the spectrum is chronic pancreatitis, which is an irreversible destruction of the pancreatic parenchyma, and usually it occurs because of repeated attacks of acute pancreatitis. So, the presentation can be easily remembered by three P's: pain. The pain in chronic pancreatitis is often dull and burning pain. The other P is pancreatic insufficiency. So they are insufficient in two ways: either exocrine, in which they will have staturia, weight loss, or endocrine, in which they will develop diabetes. And finally, the third P is periods of acute on chronic flares of pancreatitis. You don't need imaging again to diagnose, but if you do, then you are basically going to see an atrophied pancreatitis or calcified pancreatitis. And as we can see in this picture marked by the arrow, the most common type of calcification that we see is an eggshell calcification. The labs for chronic pancreatitis may not show anything different, so the amylase, the lipase levels can also be falsely normal or mildly elevated. In ED, the management principles are the same as acute pancreatitis, and that is pain control, fluids, and electrolyte imbalance checks. Finally, the last topic is pancreatic cancer, a lethal and aggressive cancer. Generally, when a patient presents to the ED with this, they present late and the tumor has already metastasized. The clinical features depends on where the tumor is. So if the tumor is in the head of the pancreas, then they will generally come with biliary obstruction. And if it is in the body or tail, then they come with vague abdominal pain or late symptoms. Remember that a newly diagnosed diabetic patient can also have pancreatic cancer. The triad for pancreatic cancer is pain, anorexia, and jaundice. But there are also red flag signs that should be identified as potential pancreatic cancer. So, the first one is painless jaundice in a patient. The second is if diabetes gets newly diagnosed, especially in an relatively elder patient. Third is unexplained weight loss and fatigue. Fourth is migratory thrombophlebitis, which has a better name called Trusosine. Again, the gold standard for diagnosing pancreatic cancer is CT with IV contrast, and generally, these patients come with a very poor prognosis. So, the things that we can do in ED is just make their stay comfortable by appropriate pain management. This brings us to the end of this lecture. If you liked it, make sure to like, share, and subscribe to the channel for more such content.